some live surgery here in the corner of the room by my skilled colleagues. Okay? So that's an additional delight for you. And there are some visual aids for you to have a look in whilst I'm talking. So, this is my hospital. Hands up, who knows UK guys, where's this? This is Kenyatta Hospital, the National Hospital in Nairobi, and I think it's fair to say that they were both designed by the same architect, so fairly brutal architecture, but the people in Plymouth are nice, work in this hospital, and the people in Kenyatta are very nice, having visited there. So don't make appearances put you off. You've seen this map before. This is where I'm from. This is the Plymouth area. And so today we're going to revise pelvic anatomy. We're going to talk about the classification of pelvic fractures, which even if you're not an orthopedic surgeon or doing orthopedics is really important because it will allow you to predict all sorts of things that are going to happen with this patient. And then from the perspective of working with MUP, we're going to talk about the principles of managing pelvic fracture in the first hour after admission to this hospital, the first day, and then the first 2 weeks. So not all the complex stuff, the simple stuff, to help you save these patients' lives. So, please hand it around. Pelvic fracture anatomy. The bones of the pelvis is a ring like a biscuit. And you can't break this biscuit in one place, you can't break the pelvis in one place. So if you see a fracture that's very obvious, and when you see a fracture, there's going to be another fracture or a ligament injury elsewhere. Everything in red in this talk is a take-home message. Okay? So if you're feeling a little tired, then you concentrate on the red bits. So the pelvis is made of sacrum, labrum, and pubis, and there are some joints that don't really move much. They're not like our elbow joint or our hip joint. They're very stiff, fibrous joints. But when they're disrupted in pelvic fractures, they need to be treated. So you're all familiar with the appearance of a pelvis. It's a ring, and there are various parts that are labelled here. We don't have to really concentrate on specific names. This is more a case of having a global awareness of the pelvic bone. As well as the bones, there are the vessels, and as you have a look at the model, just look at where the plasticine, red and blue vessels are. They lie across the sacroiliac joints, you can see it here. And so in certain types of pelvic fractures, the vessels are disrupted because arteries are quite springy and elastic, they don't tend to rupture. The veins are thin and they easily tear. So most bleeding in pelvic fractures is venous. It's about 80% of the life-threatening hemorrhages is venous. And that's important when we consider how to treat this later on. As well as the arteries are the nerves. You'll be delighted I haven't named any of these nerves, because we don't need to know that, but in principle, look how many of these nerves are coming out of the sacrum. These are nerves that control your bladder and bowel and sexual function. And a significant number of patients with bad pelvic fractures may have dysfunction of those things, so you need to address that in the long term. But that's not going to concern us today. Of course, there's some other contents of the pelvis. There's the bladder, the balloon, the other balloon, I hope you're all recognising that's the bladder, and the uterus, the pregnant uterus, the colon, and the rectum. So, classification of pelvic fractures. It's important to know these as it directs your treatment and predicts associated injuries. And you might think you're going to struggle with this if you don't look at x-rays. But by the end of this talk, we're going to go through 4 scenarios. I suspect you'll be able to classify the pelvic fractures. So, the first pelvic fracture pattern is a lateral compression fracture. Okay? So that's where there's a sideways force that has fractured the pelvis. Okay, this is looking at the pelvis from the top. So imagine if you're lying on your side and then something heavy lands on your side and it crushes the pelvis in this direction. Okay? So the lateral compression. The next one is anteroposterior compression, or APC, and that's the classical open book fracture. So if you imagine the pelvis here, if there's a force that hits the front of my pelvis, the front of my pelvis is going to spring open and the back will stay intact. So the book is opening from the front and hinging at the back. I don't need to worry about the various sub-classifications, other than to note, here is the pubic symphysis at the front. It's slightly wide, it's slightly wider, and it's very wide. And you can imagine this, that only should be a few millimeters apart. If it's this wide, there's got to be a significant disruption in the back, that may be ligamentous. Okay? And remember, APC injuries, the blood the veins over the back of the sacral, over the front of the sacroiliac joints, and you get injured. The final one is vertical shear, which is a fall from a height. And that happens then if this patient will be standing on their left leg, that will take the force and the whole hemipelvis will be driven up. Will you happy? You're scratching your head.
No, I'm scratching your face. Okay. Completely different. This is lateral.
So please rather than intellectual uncertainty. So, lateral compression at the top. Okay? So sideways. AP, open book, vertical shear. And there are some injuries you'll look at and you'll say, I just don't know. And that's fine. Probably lots of pelvic surgeons say, I just don't know. But have a go, because you're probably right. Final thing to say is, in lateral compression injuries, the pelvis looks squashed in. I like that term because it still makes sense. Whereas here, the pelvis is open, it's bigger. So when it comes to the x-rays, is it squashed in or is it bigger? So what about the associated injuries? Lateral compression, you tend to get visceral injuries on the same side. So if I fracture on this side, I'm going to damage my left chest wall and my spleen. Vice versa, liver and chest, the other side. You rarely get life-threatening hemorrhage from the pelvis in this fracture. Okay, just the way it is. Anteroposterior compression injuries, as you can imagine, because the urethra and the bladder is just behind the pubic symphysis, tends to have urethral injuries, but also potential for life-threatening hemorrhage in the first 24 hours. It's in red, you need to remember that. Vertical shear fractures, they tend to have neurological injuries to the sacral plexus. Now, of course, when I say associated injuries, I just mean what's happening here. I don't mean what's happening particularly in the rest of the body, because you've got a vertical shear, you might also hit the head, you might also hit chest injury. So here's some examples. Who's going to have a go? First of all, anyone shout out? Classification? AP, yeah, so the pelvis is bigger. Yeah. Associated injuries? Urethra, bladder, and hemorrhage, yeah. Now, our live surgery is about to start, so minor. Minor? Is it okay? Our live surgery is going to start, so they need the pelvis back. Okay, so we've got APC3, so life-threatening bleeding and urethral and bladder injuries. Okay. How about this one? Squashed in, opened up, vertical. Squashed in, lateral compression. So the forces come from the side, yeah? So associated injuries, visceral. Life-threatening bleeding is unlikely from this. Okay? So you're not going to relax if you see this, if there's hypertension. Of course you're not. But you're going to think about causes outside the pelvis. How about this one? Vertical shear. Can I convince you that the left hemipelvis is higher? Yeah. You can see, this is obvious here, but if you look at the sacroiliac joints there, you see there's disruption. So there might be a fracture here, there might be a ligamentous injury there. Neurological injuries to the sacral plexus and other injuries outside the pelvis. How are you getting on guys? Good fun. All very quiet there. You have got a kit? Yeah. Karen, no kit. Okay, so we're going to move on to pelvic fracture management. So here are the Nanuki tools I think you need to manage pelvic fractures. Okay? You need a well-trained team. And after today, I think you'll be better trained. Good. Use tranexamic acid. We're not going to talk about that in detail, but I've got two experts, Will and Catherine at the back there. Catherine in particular is responsible for trauma transfers within our southwest region. And so she's used to dealing with patients in the first 24 hours. Blood products, again, any questions, we'll direct to Catherine. Urinary catheter, because you need to split the urethra if you need to. Pelvic binder or sheet, and we'll cover that just now. Traction, so if you've got a vertical shear fracture, you might want to put traction to bring the leg hemipelvis down. And you need a theatre. Okay? Take home message. We're going to take this home. I've checked with Dr. Nadia. We agree. CT is not necessarily needed at all in the first 24 hours. Not least because you don't have it available, but you don't need to feel bad about that. You can manage these patients just as well without CT. So what about a pelvic binder or sheet? So here's what's available in high resource settings. Okay, it's just a fancy big valve that goes around to brace the trochanters. Okay, so even though it's a pelvic fracture, we're not putting it around the pelvis. We're putting it around the brace trochanters, and that's because we won't really control the fracture that well. This is a sheet, standard bed sheet that's been wrapped around the pelvis in the same position. That's the brace trochanter. It does exactly the same job. There's no difference. And so if you've only got a sheet, that's fine. You can either tie a knot in the front of it or put some tape around just to hold it, and you might want to adjust it if the patient's got too much pain or you're not controlling it enough. So when do we put a pelvic binder or sheet on? So the indication is a high energy injury with a suspicion of a pelvic injury. Okay? So I'm not saying a definite one, and this could and probably should, like it can happen in the pre-hospital phase, but I don't know whether it is just yet. Because if you have someone with life-threatening hemorrhage from a pelvic fracture on the scene, you want to start controlling that before you come to the hospital. And I want you to feel relaxed about putting a binder on. You don't need to worry about whether you've got it right, whether you've got it the correct mechanism of injury that you're treating. So the binder goes on at this level. You can see this is an AP compression injury. And you can imagine it squeezing it together. And what you're trying to do is compress any bleeding at the back of the pelvis that's occurred with this injury. So what if you put a pelvic binder on this injury? If you don't have the x-ray maybe before you decide to put the binder on. This is a lateral compression injury. Are you going to cause harm by squeezing that bone and pushing, making it squash further? The answer is no. We'd rather you over-treat this patient, and in fact treat them in a way that they don't need, because there's no life-threatening hemorrhage here, because you don't have the information at the time you need to put the binder on. You might not get this x-ray until 2 hours after the injury, or 6 hours after the injury. The problem with a binder or a sheet is that you can only really put it on for a short time, maximum 24 hours. We probably would prefer less than 12 hours. And that's because underneath these binders you get pressure sores, and they can be very bad and difficult to treat. So you certainly shouldn't have the binder on for 2 or 3 days. That would be bad. You can hear the operating centre, they're actually quite quiet. What they're busy doing at the moment is putting on an external fixator. And this is just the same as a binder. It doesn't do anything different. This external fixator is not for the mechanical instability in the pelvis. It's just to hold the pelvis reduced to treat bleeding. So you won't see this put on very often because most patients tend to have hemodynamic instability. So when you're managing these patients, if you're going to the emergency department, I want you to ask yourself a few questions. First of all, what was the energy involved in the injury? Is it a mechanical injury or is it a fall from standing height? Because both can get pelvic fractures. Is there any hemodynamic instability? So has the patient got hypothermia shock? Is there mechanical instability? Is the bony pelvis very unstable? As non-orthopedic surgeons, you won't particularly know that. It doesn't really matter. But what I want you to not do is to say, I've got an unstable pelvic fracture patient. Because the language is confusing here. Because the person you're talking to, if you're referring to Dr. Nanya, he doesn't know whether that's mechanical instability or hemodynamic instability. Okay. So make sure you're precise with your terms. What about CT? Do you need CT? 10, 15, 20 years ago in the UK, we used to call the CT the donut of death because patients passed through it after their trauma and the delays led to death from hypothermic shock. Now, we're fortunate to be able to get someone through a CT scanner and back into the emergency room within an hour. And we are still selected. Some patients just bypass straight to theatre in my hospital. But now that we've got better access to CT and quicker access, we use CT more. Okay? Just got to be aware that hypothermia can cause a patient to die in a CT, and we don't need it in a NUQ. And you need to consider how long it's going to take you to get the patient to the CT scan, and how long it will take you to get a report. And even the moment a CT scanner arrives in a NUQ, you've still got problem number 2. And unless you're still reading the scanner, or reading the images, it's not going to take you any further, and there's probably going to be some delays. One thing to be aware of is if your pelvic X-ray is normal and you've got a binder on, you need to take another X-ray when the binder is off. Because if there's just a ligamentous injury, the pelvis might spring over. So, message in red there. So, the first hour after admission, here's what I think you need to think about in Manuki. An ABC approach. Place the binder sheet if you suspect a pelvic fracture. Don't worry that you haven't got an X-ray yet. And if a binder or a sheet's been put on pre-hospital, don't take it off. You treat the hypothermic shock just the way you would do in any other way, and you see whether they're responding or not. You get a pelvic X-ray, and you see what the pelvic fracture type is. And feel confident to put a urinary catheter in ABC injuries. There was concern that if you catheterize, you might damage the urethra more, but in fact, the answer is no. It's safer to do a urinary catheter if you're an experienced person. We need to splint the urethra if there's a urethral injury. So, thank you. So, the X-Fix is being handed around at the moment. So, in the first 24 hours, again, you need to repeat your ABCDE approach. If your ABC is present, you need to swap it for a binder, from a binder to an X-Fix. And you need to assess whether the fracture is open. So there may be pieces of the pelvis that have poked through the rectum or the colon, and you can imagine that if there's contamination with time, they'll get an osteomyelitis and die. So if you know that there's an open pelvic fracture, then we recommend a stoma to divert the flow. Even in the first 24 hours, we're still focused on just keeping the patient alive and dealing with these other things. The CT is only going to help us to kind of work out how to manage the patient. So you don't have to get it even within the first 24 hours. Note I said in the first 2 weeks, we're going to go back and look at the patient and do secondary surveys, tertiary surveys, and maybe get your CT within the first 72 hours. And then you'll orthopedic decide what they're going to do. Is everyone happy so far? Any questions? Where's the pelvis? Please pass it around because they need to do another operation. Nick?
So, Chris, are there any things in the history or any clinical things that have to decide what to do if you can't get an X-ray or the patient is clearly ill and you've got to use an X-ray?
So just take them straight to theatre?
Or, no, you've got a patient in front of you on the patient being wheeled into hospital. Is there anything in the history or an examination that is very useful that can tell you what to do?
So early on, you just won't see any bruising around the pelvis. Okay, so the patient hit by an tattoo on the street, they will just look pale and shocked. Okay, and for those of you who deal with shocked hypothermic patients, they will just look just like that. So I think if you're on the street, you just have to maybe get a binder if you can, a sheet from anywhere, and you do all the ATLS things, protect the neck, the airway, and then just scoop them into hospital. If your X-ray machine is broken and you've got a shocked patient, and you know that there's some pelvic trauma and what you can feel or see, then take them to theatre and do that. So don't worry if you've wrongly called, this isn't ABC, and you've done that, that doesn't matter, because that's not going to cause any harm. Okay? So the fractures you're not sure, is this ABC or not, then put a fixator on. It will do something for mechanical stability, but it's only because the definitive surgery is going to be something that you don't use that technique. Is that answer? Any others?
Just to mention that at examination, the researchers are just by usually to push the pelvis and extend it as you suspect to got a pelvic injury.
Yeah.
So long.
And you push both sides, you will actually feel how it's going together, and the patient looks suddenly a different shape. It's really quite alarming when you see that. What we don't want to do is do lots of this because you're damaging any clot forming posterior in that electric as well. Okay. Absolutely. So we're going to still, I'm deliberately not focusing on the ATLS principles here. All the standard trauma principles, you must use those. So for high energy injuries, then you use your standard ABC. Yeah, for sure. And that collar can stay on until you feel there's no issue. Okay, so we'll move on to some scenarios now. So number one, 78-year-old, well, one strap from standing height, can't wait on the left leg. There's plenty of pain, feels psychologically shocked and tells people that she's shocked. The ABCs are fine, she's not got any hypothermia shock, her leg lengths are equal, and she feels pain moving her left hip. Who wants to have a go? Do you see a fracture here? So fall from standing height, elderly lady. We have about 500 patients a year in our hospital coming with this. This is an osteoporotic pubic ramus fracture. Very common. There will be a invisible fracture at the back end of the sacrum, maybe a small little fold. But this doesn't need any particular treatment. So I'm including this as actually one of the commoner injuries in the UK. It's not very common here, but you need to be aware that it's within the spectrum. Okay? When she comes into it, she doesn't need a binder, she doesn't need any surgical treatment, you don't need to catheterize her, you can let her mobilize her pain on that. Okay. How about this one? 80-year-old from San Bruno, from 2 days ago, can't walk, maybe see fine, but again, she's a bit short, and moving hip. You can check that well. Anyone? He's fallen from a tree. Remember, the mechanism of injury is really helpful for you. So he's not been crushed, he's fallen and landed on this left leg. So can I convince you that this pelvis is vertically unstable? Yeah? And if you see shortening of the leg and there's no lower than long bone fracture, you know it's coming from the pelvis. Okay. So does he need a binder? He needs traction, he doesn't need a binder. Thank you. And I'm really pleased that our clinical officers and anesthesia are engaging in this. The crossover, no, seriously, the crossover between you guys is good, and you show lots of interest, which is really helpful. Street traction, no need to catheterize this patient, but possibly where it's fallen from the tree, you might have some other injuries. And the CT scan can happen sometime in the first 3 days. Dr. Daniel doesn't need to know about this on a Sunday to busy refer elsewhere. You can just have split traction. Okay, 27-year-old crushed by a buffalo 6 hours ago. Pain in the pelvis and chest. Okay, so he's been pushed over by a buffalo. So the mechanism is important. If you don't know whether he's had a crush like this or like this, okay, but you know it's a high energy injury, right? There's his blood pressure. What's going on? Happy? Not very happy? Not the up to here. So he's in hypothermia shock, right? His leg lengths are equal. Saturation is 92% on air. He's a young man. All good. So here's his X-ray. Is the pelvis squashed? Is it open? Or is it vertically unstable? We know it's not fallen from a height, so we can forget vertically unstable. So is it open or is it squashed? Squashed, so lateral compression injury. So, what does that mean about hypothermia? It means it's not very likely to be from his pelvis. Yeah. Is his chest? Not a happy chest X-ray. White out on the left side, blood in there, probably. Yeah, need a spinal shift. So in him, it's a lateral compression injury based on the X-ray. No pelvic binder needed, but don't worry if you put one on. Doesn't matter, he's not caused harm. You don't need traction. He probably needs a thoracostomy or at least a chest drain. He doesn't need an X-fix. and significant hemorrhage is unlikely to be from the pelvis. Now, if you put a binder on and you think it's an open book, and you put an X-fix on, no one's going to criticise it. That's not a problem. But the hemorrhage is unlikely to be from the pelvis. So then we need a CT or someone. Happy with that? Has the pelvis go back? Pretty quick. Only one operation left. What about this one, number 4? 26-year-old boda driver. A boda is a motorbike taxi rider for most UK people who don't know. Blinded with a rear obstruction on fast road, he's gone too fast, he's piled into the back of the truck at high speed. He's got chest pain and pain on the right side of the body, and it's an hour since injury. What going on? Examination of observations, happy, not happy? Not very happy. He's shocked, isn't he? He's a young guy, he shouldn't really have a blood pressure like that and tachycardia, unless it's just pain. His leg length's equal. Okay, so we can forget vertical shear, it's not that. Anyone? What's the mechanism? AP compression. The pelvis is wide, it's not squat. You see, it's easy, isn't it? It's not difficult. It's wide. So, associated injuries, life-threatening hemorrhage from these veins at the back of the pelvis that are bleeding. What do you need to do? Squash it together with a binder or a sheet, and then within 24 hours you've got to convert that to an X-fix. So there's no doubt here. You know if he's got life-threatening hemorrhage, you know he needs an X-fix. Even if he's not got life-threatening hemorrhage, if he's going to be transferred down to Kenyatta, bumpy ambulance, he's got some bleeding from the vein to the back, maybe he gets to think and then he starts bleeding. So he probably needs an X-fix, I would say. Because he's going to need the definitive surgery that our surgeons are doing this there. Okay, so pelvic binder, X-fix for 24 hours, so you've got the answers. The thing I haven't mentioned here is that if the X-fix doesn't control the bleeding, there is a small chance that we need to do a laparotomy and pelvic packing. So rib packs into the pelvis to compress the veins. But that's extremely unlikely because most of the time we control it with your X-fix. He then obviously needs his CT scan, and he's going to have the pubic symphysis plating that thank you, Nick and Guy just before. So the X-fix is not good for the long term. Happy? So in summary, remember the mechanism of injury. Vertical shear, open book, squashed in, lateral compression. APC injuries are the ones you want to really worry about. Because those are the patients that come in and bleed to death from their pelvis. Pelvic lines can be life-saving, and you should be encouraging pre-hospital staff, the ambulance crews to use them if they're not. You've got to remember to check for open pelvic fractures. It might be obvious, it might not be obvious until you get a CT scan. And the CT scan is not really needed for the first 24 hours. So don't put this patient at risk and send him elsewhere to get a CT whilst you don't have one. Any questions? Now, doing a robot that is technically really demanding, where someone really knows what they're doing, and it's the equivalent of cross-clamping the aorta, or even just putting pressure on the aorta. So if someone comes in here, let's say they've got pelvic bleeding, and their blood pressure is 60 and they're pre-arrest, then the best place for them is to go straight to theatre, probably even before any x-rays. You'd probably do thoracostomy straight away, and then you would be prepared to do a thoracotomy and a laparotomy and pressure on the inferior aorta. Because if it's a radical clamp the aorta, it doesn't matter, you put pressure on it. And that's the same as with revert, and you've all got the skills to do a laparotomy and put pressure on with this. So it tells me something we're not doing in the UK to staff that sort of rota to provide that service really hard. And you're better off just getting them to a theatre. So what I've presented here is, theatre is a central part of your tool, rather than any other fancy sort of techniques that appear in some places. Any other questions?
Any idea done laparotomy and compressing the aorta to make sure the patient's on a hard surface.
Yeah,
Is it?
so someone is arrested and then just put pressure on with a swab on the descending aorta whilst they're going to theatre. Rather than any balloons, catheter, sort of things. It's just too hard to organise it. And these patients come in all times of day and night. So you've got to have skills that a medical officer can use rather than something else. Dr. David, can I invite you to comment?
Thank you, Dr. Christopher. I think that's very nice way, because pelvic fractures are some of those things that you need to get very early on. And remember, among the 5 places you can use abdominal pelvis is one of them. So if your patient is in shock, when you think about the 5 places, you think about the chest, you think about that, which is one long ones, and the external bleeding. So one must think very early, because you are at risk of losing a patient. We about 2 months ago, we went to the hospital on a Sunday when I was going to church. This patient was transfused 5 units with helium, and she threatens me that they won't take a patient to CT scan. And I was riding my bike, I said, you can't take a patient to CT scan. Patient was in shock, and they were about to go. I said, I'm coming down, so I was on my bike and rode down there for the patient in shock. And we cancelled the CT scan. And that's very, very important. And so remember the discussion, I said, you take the patient for CT scan, you lose the patient.
Wow.
So we go to it, we find the rupture. So we do our harassment. I say, from here now, we call them anesthetists, and we go in, first thing we find, patient had the blood was gone, this was down the line. We discuss with the anesthetist, we could use this patient in theatre, but theatre is the much safer place than a CT suite. And right there, we were able to get through, and I had also done the parking. There is the issue of embolization, and it is not, I think, one of those things that you do is sufficient conservatism.
Yeah. You spend a minute talking about embolization because you'll read about it. So remember, I said the life-threatening hemorrhage comes in APC injuries, and 80% of it is venous. And you don't need to embolize the veins. If it's arterial, you'll see that on a CT angio. Okay, so you'll see contrast escaping from the arteries on a CT angio. And in that case, interventional radiology can embolize the internal iliac, which is the most common thing. Okay? But actually, if you don't have it, you can tie off the internal iliac. Okay? So it's better and you need to not worry about that, go to theatre, get the general surgeons in, tie off the internal iliac, tie off both of the internal iliacs, necessary from bowel bleeding. It's very, very rare. It's almost always venous. So then call in your friends, okay? So don't just maybe it's really stressful, you can't find out down there. Get the general surgeons in. You know, it's just hemorrhage, you've got a tunnel for tap, it doesn't matter that it's a complication.
And that medical can actually go with the reason why, because when you don't practice, you just need abdominal mass in place. You still lost that patient mass later, but the best chance for you is in theatre, not a CT suite. So Dr. Mtisi was the discussion. I said, you know CT scan, you're going to do that. Cancelled my child service, and we headed to do it. And that's the big, for me, the emphasis is you are already there, not going to a CT scan. The CT scan is important, it's not going to save your life. So if you are in the life-saving stage, CT scan is of no value at all. And it doesn't matter anything, whatever you see at the CT scan, you may not make, you shape your decision. So it is, what you're discussing is something you have gone through. It is real, and this is probably what, 2 months ago? 2 months ago. And so it is real. So you're transfusing your patient, you continue transfusing. CT scan is out of question. Even if it's available here now, it's not going to happen.
Unless you've got a radiologist who will report it within the hour. And even then, you're still going to go to the theatre, ask the radiologist.
And if the choice is between theatre and CT scan, the patient is sure. Theatre is the obvious option. I mean, it's no brainer that you want to go to theatre and a CT suite. And Dr. Mtisi was this last week.
So we still sometimes have this argument, discussion in our resuscitation room. But we've got a lot of senior decision makers there. So maybe 1 in 20 trauma patients, maybe they go straight to theatre because it's clear they need damage control surgery. They then can go back to CT But just remember, the surgery is an ABC approach, isn't it? ABCD approach. So if C is life-threatening, you need to go to theatre and then go back and check out D with a CT scan to look at the head later. Because you still might need to do something here, but the C is more important.
But at C, and that's why in a way at C, it's able to get a part of managing C, even long before you go to that first level. You go to that. It was actually
Very close.
No, that's good.
What was he doing?
What's written down here?
What is he doing? And I have to blood group that you don't know. Remember that the book that we had in that one? I was going to do that.
Okay.
So if we did not have red cells, we could give the FFP and the cryo, but
So here, and you haven't got those, and you don't want to do it.
when you say plasma times, do you mean like gel-fusion or?
Yeah, transfusion.
Yeah, we moved away from gel-fusion because we found that we don't have such a good survival rate. But again, if you've got nothing, then you have to use what you have.
So you've got to replace volume with something. Crystalloid is probably the least preferable. But if you haven't got anything, still give crystalloid.
I think so.
Yeah, absolutely. So there are two components on. You've got to deliver some flow, and you've got to deliver something that's going to carry oxygen. Those are your two goals. So the other thing you would consider is lower targets for your blood pressure, both to reduce the bleeding and to accept that that is what you are aiming for. There's no point in pouring more in, increasing the pressure, which just increases the bleeding. So if all you've got is a crystalloid or colloid, you give that because flow is important. You recognise that your oxygen carrying capacity may be going down, and you look at lower blood pressures, which obviously affect all your organs, but you are going to stay alive if you keep some sort of condition.
Thank you.